The case of today is a case of a 67 years old gentleman with arterial hypertension, diabetes, previous non-ST elevation MI that was treated with angioplasty and stenting of LED. The patient was referred to our hospital for a new acute coronary syndrome. Here in this slide you can see the electrocardiogram at the admission. Blood tests demonstrated an elevated troponin T levels and an hypokinesia of lateral wall was documented with a normal rejection fraction of 57%. Here in this video you can see a total circumflex artery occlusion that was selected as the culprit lesion in this particular patient. A critical stenosis of the right coronary artery was also documented in this patient. The culprit vessel was treated with a deployment of a drug-eluting stent with an excellent final result. The right coronary stenosis was treated with a drug-eluting stent, as you can see in this slide. Finally, we documented an intermediate non-culprit stenosis of distal left anterior descending artery. The LED stenosis was interrogated with a pressure wire. Using IV infusion of adenosine, we calculated the FFR that was in this particular patient 0.72, and also we calculated an index adenosine independent that was 0.84. The IFR was 0.84. Therefore, based on the pressure wire data, we stented with the BVS this LED lesion. In this slide, you can see the medical therapy at discharge. In conclusion, in this case, the culprit lesion was treated with a drug-eluting stent. The critical right coronary stenosis was also treated with an additional DES, and the non-culprit intermediate LED stenosis was interrogated with the FFR and IFR, and then was treated with a BVS. Just a few slides to the use of IFR in acute coronary syndromes to interrogate the non-culprit lesions, and it is my pleasure to present some of the forecast study that has been done in our institution. It is well known that optimal management of multivessel disease in patients with non-ST elevation or ST elevation myocardial infarction treated with the percutaneous coronary intervention is still unclear. The evaluation of non-culprit lesions in patients with acute coronary syndromes remains, therefore, an important and unsolved issue. Recently, IFR has been shown similar diagnostic performance compared to FFR for the identification of stenosis responsible for myocardial ischemia. The adenosine-free alternative to FFR could boost the use of intracoronary pressure measurements in the cath lab. The aim of the forecast study was to evaluate the instantaneous IFR measured during the wave-free period for the adenosine-free evaluation of non-culprit vessel stenosis in patients with acute coronary syndrome. The standard FFR using IV adenosine infusion was also calculated. In this slide you can see in the left panel the correlation between IFR and FFR, whereas in the right panel the Bland-Hartmann plot demonstrated a good correspondence between the two parameters. In this slide, you can see the log curve and the accuracy analysis. And as you can see, the sensitivity was 0.76, whereas the specificity of using IFR was 0.84. And the same data were obtained in patients with stable CID in the left panel compared with the IFR calculated in patients with acute. In this slide, you can see the potential advantages of IFR. In a multivessel coronary artery disease, especially in the setting of acute coronary syndromes, a simple and quick functional stenosis evaluation would provide significant functional information. Multiple pressure wire assessments in different vessels would be made more acceptable due to the avoidance of adenosine administration. In conclusion, the forecast was the first study that specifically investigated the use of IFR in acute coronary syndromes. In the forecast study, resting IFR measured during the wave-free period in non-culprit lesions showed an interesting classification match with FFR. However, the clinical value of IFR should be tested in a large study with the clinical endpoints. And I have to thank my team at the University Magna Graecia that did many data on the forecast trial, and thank you for the attention.